What would you do if your life depended on not one, but multiple organ transplants? Would you trust the system to take care of you? Or would you fight to make sure your voice was heard? Medicine now offers patients with deteriorated end organs a chance at another life. Organ transplants can be life-saving and life-extending, but they can also be life-ending. And they do require in-depth monitoring on an almost daily basis. Our guest today needed a double lung transplant and a kidney transplant, but her journey to that surgery was not straightforward. Here's a story of survival, but more importantly, it's a testament to the power of self-advocacy in medicine. Navigating the healthcare system, challenging medical decisions, and pushing for the right care can mean all the difference between life and death. Welcome to the Health Exchange. Thanks for joining me, Dr. J. Rutland, and my co-host, Savannah Shiles, as we talk with Matison Deaton about advocating for yourself in the face of systemic obstacles. Maddie, first of all, thank you for joining us. What I would like to start with is tell us about yourself.
First of all, thank you for having me. I'm really excited to be able to talk about cystic fibrosis and share my transplant journey and all that came with it. So thank you for giving me this opportunity. And I am a 32-year-old living in San Francisco. I am from Alaska, so I grew up, fishing, camping, all the outdoors activities, skiing, and moved to San Francisco in 2022. And now I am here. I do a bit of writing. I collect puzzles, and I do as much as I can to spread awareness about CF and transplant.
I saw your puzzle collection, and it's very impressive.
Thank you. Yes.
And cystic fibrosis, when were you diagnosed? Do you know what it is? When did you find out exactly what it was?
I was diagnosed at 18 months old. In 1993, it was confirmed with a sweat test, which is when they just measure the sodium content in your sweat. And then probably 6 months later, I found out my genetic mutations through a blood test. So I was just an infant, just a little baby, and I didn't know, what it was. I knew that it was going to be lifelong. I knew it was something that, was present every day, anytime I would eat or, go to sleepovers and things like that. But I didn't fully comprehend what it was until I was a teenager, maybe 13, 14, when mostly I realized what it meant when it really started to impact my health and my daily life more.
When you were 18 months old, was it your parents? Was there some sort of signs that you were showing, or how did they know to test you for your sweat?
One day, my mom or my sister, I think, came into my room. I was sleeping in a crib, and my sister couldn't wake me up. And so she went and got my mom, and my mom was trying to shake me awake a little bit and ended up with an ER visit and a referral to a pediatrician. And then my pediatrician is who initially thought maybe she could have cystic fibrosis. I had a rectal prolapse, and I had basically the symptoms of malnutrition. And so my pediatrician thought she should be tested for cystic fibrosis.
And it was all because of the symptoms of malnutrition.
Yes, pretty much.
Wow.
And when they said they couldn't wake you that night, do you know what the cause of that was?
I don't really. I don't think my parents really knew what the exact cause was. I don't know if I was very sick, if I had some kind of virus or something at the time, but I was just very lethargic and wasn't easy to rouse. I don't know why.
Did your parents know at that time that they were carriers, or did they not realize until after?
No, they did not know. I mean, my mom was a nurse, so she had, heard of cystic fibrosis, but neither one of them knew what that meant.
So, just for the audience, just real quick, cystic fibrosis is a disease that is a genetic defect. And essentially, and I've said this before to all of you, your lungs are a bunch of pipes that lead to a bunch of balloons that are all stacked on top of one another. Now, when you zoom in on these pipes are built with airway epithelial cells. Now, we call them airway epithelial cells just generically, but there's many different types of cells. There's your traditional airway epithelial cell, there's secretory cells, there's ionocytes, there's deuterosomal cells, there's neuroendocrine cells. But when you look and zoom in even further microscopically at the airway, you'll notice a few things about these cells when you zoom in. On the outside of these cells, towards where your environment is interfacing with these cells, you see these molecules that we call cilia. Cilia are responsible for beating back and forth and taking material that you might inhale that your body doesn't like and bringing it back up so you cough it out. And to do that, these cilia require mucus, and there's many different types of mucus. There's MUC5A, there's MUC5B, MUC5AC. All of these things, the mucus, the cilia, they all work together cohesively. The way that we produce the mucus, because as you guys all know, when you guys are coughing, you can cough up mucus, is we basically make a certain type of fluid. And that fluid has different ingredients, but there's a ratio to these ingredients. Just like when you are eating your grandmother's best recipe, there's a ratio of ingredients. You can't have too much salt, you can't have too much pepper. Cystic fibrosis, there are actually membrane channels. These are proteins that are in the membrane of your cell, specifically the secretory cells of your airway. And what they're transporting is different ions across this membrane, chloride, sometimes sodium, but what we're talking about here is chloride. Now, in cystic fibrosis, this channel is defective. Either the protein misfolded and it's not working as well, or the protein's absent completely and you don't have it, or you have something in between. So what happens? So what happens to the airway is that your mucus is not as thin, it's a little bit thicker. When your mucus is thicker, your cilia feel that pressure, so they can't beat back and forth as much. And what you're actually creating is a nice bath for bacteria to hang out in the airway and chill. You're also creating thicker mucus. Now remember, when you take that big breath of air in and you're taking the oxygen out of the air to try to put it into your alveoli, those balloons, if you block that airway with mucus, we call it hypoventilation. You can't breathe very well. So again, cystic fibrosis is a disease that's caused by a lack of function of a membrane channel that we call CFTR, right? And so if you don't have it in the airway, it leads to what I just mentioned. But CFTR is all over the body. And what you heard from Maddie was it really affected her GI tract. And those are the primary places where we're going to see it as physicians. Again, I'm a pulmonologist. I see it frequently. Is you're going to see it affect not only the airway, but you're also going to see it affect the GI tract. And these patients might have bowel obstructions. These patients might have, loose stool. These patients might have abdominal pain. But whatever symptoms they have, it's directly related to that lack of function of that ion channel. And I'm sure you learned that along the way, right, Maddie?
Yes, definitely.
When you were growing up, did you have a lot of airway symptoms? Did you just have GI symptoms? What symptoms did you have most of the time?
I had so as a kid, my airway was an issue as far as, catching viruses or getting infections from like the soil around me and things like that. But my biggest hurdle as a young person was my GI system. I think I required IV antibiotics 2 or 3 times as a young toddler, but I dealt with GI symptoms every day, and then I still deal with them. Once I was diagnosed, I was immediately placed on pancreatic enzymes because I had pancreatic insufficiency. That was the number one thing they thought causing the brunt of the issues I was facing at the time. And so I dealt with pancreatic insufficiency, like you said, extreme abdominal pain, a lot of constipation as a young kid. Sometimes I would end up in the hospital because of the pain, because of not being able to go, and things like that.
How young were you when you were having to go through this and be at the hospital all the time? And what emotional toll did that take on you?
So, as far as how young I was, I didn't have a prolonged hospital stay until I was probably 15 years old. I would, go to the hospital with cystic fibrosis. You have very frequent checkups every 3 months. You're going in to see your whole CF team. You're seeing a pulmonologist, a nutritionist, a social worker, all of those things. That's pretty frequently. And then add in if you get an infection. as a kid, I didn't do inpatient IV antibiotics. I would get an IV or a PICC line. And even as a young kid, I have pictures of me with when they used to put the board underneath the kid's arm so that they couldn't bend their arm and everything like that. But with the emotional toll of it, I don't ever really know how to answer that as far as when I was young, probably before I was 15, because I started from a young age. It was something that was in my normal
It was your normal.
routine. Yeah, I didn't enjoy it. I didn't love getting an IV or, it wasn't easy getting my blood drawn as a young kid, but I only knew it as something that I had to do. I didn't really think of it until I was older as like something different than everybody else. And so therefore it was so much harder.
Just real quick, when you think about the GI tract, which includes the esophagus, the stomach, small intestine, large intestine, you have this organ called the pancreas that sits next to the liver. It sits next to the small intestine. The pancreas is both an exocrine and endocrine organ. And so what I mean by that, when I say that, is exocrine meaning the pancreas is responsible for secreting enzymes into your small intestine to allow the food that you eat to be broken down appropriately. That's what the pancreas does. The pancreas is also an endocrine organ because it produces insulin and glucagon and somatostatin, and these are hormones that will act distantly to help cells be more sensitive or less sensitive to glucose and such. And so when you look at this organ, because this organ is a secretory organ and secretes these enzymes, it uses that CFTR channel to produce ions across that membrane and allow these enzymes to be secreted appropriately. And so when somebody has cystic fibrosis and they don't have the ability to do that, the enzymes struggle, they suffer, they can't get to the right places. So what you heard Maddie say earlier is that I started taking pancreatic enzymes really early on in my journey because that would be helpful to her because her enzymes weren't getting to the appropriate spot to help her break down food. So her abdominal pain may be improved, or so she felt better overall from a gastrointestinal perspective.
Did you feel like you were feeling better in those early years when you would have these symptoms? Did the treatment help?
I was so young before I started the enzymes and when I started them that I can't really gauge how I felt in those first, 18 months, 2 years versus the time after. But I would notice a difference even just meal to meal if I missed my enzymes, if I forgot them or didn't take them in time. And then I ate, a meal with a lot of fat and a lot of, protein that those enzymes break down. I would end up with symptoms like abdominal pain, stomach ache, and constipation.
At what age did they start to talk to you about possible transplant?
That was much later in my life. I was in my early 20s when the official conversation happened that this is what you need. And it was entering my 20s when those eventualities started coming up. And the process, I guess, of trying to, figure out if I wanted a transplant, if I would get a transplant, if I needed one, that all started probably in my late teens.
So there are significant consequences with cystic fibrosis, right? Now, from a lung perspective, as we mentioned, because these persistent infections and persistent inflammation in the lung, this leads to lung architectural damage, right? Something the lung can't quite recover from when you have these persistent infections and you've got your immune system constantly being recruited to that area, damaging the lung's ability to gas exchange, right? The lung is supposed to take oxygen from the air, put it in our bloodstream. That's its job. But when you get persistent infections and this architecture gets broken down, you can't do that any longer. And that leads to consequences of the heart too, right,
It
Savannah?
definitely does. Yeah, yeah. We've been talking about how cystic fibrosis affects the lungs and the digestive system, which we know, but it also can affect the heart indirectly. So we see that patients who have chronic lung disease and have low oxygen saturation levels, which we see with cystic fibrosis patients, are at a higher risk for what we call pulmonary hypertension, which is essentially straining on the right side of the heart. When patients have persistent pulmonary hypertension, they are at an increased risk for what we call hypertrophy, ventricular hypertrophy. And essentially what this is thickening of the right ventricle of the heart. And this puts these patients at risk for heart failure. We also see additionally that patients who have cystic fibrosis related complications like diabetes or electrolyte issues, which is not uncommon either in cystic fibrosis patients. So maybe there's low potassium levels, low calcium levels. These patients are at an increased risk for electrical issues with the heart, like arrhythmias. Do you have a cardiologist that you follow with, or have you through your journey?
I do not have a cardiologist, and I don't think I've ever seen a cardiologist from a referral from my pulmonologist or from my transplant team. I have had a couple right heart caths to check for pulmonary hypertension and other things, but only in my pre-lung transplant evaluations where it's required that every patient being evaluated has to have a right heart cath.
Yeah, so because of the consequences of cystic fibrosis from a lung perspective and the pulmonary hypertension that it can cause, right? Which is essentially just a big right heart. What we do before people get transplanted is we stick a catheter through your vein. We go into your right atrium, right ventricle, eventually into your pulmonary artery, and we measure, as you know,
Hmm.
the pressure. We want to see if there's evidence of an elevated pressure in the right side of the heart. Because if there is, and if you do have pulmonary hypertension, especially if it's significant, then we're not just talking about a lung transplant. We're talking about a lung transplant and a heart transplant.
Yeah, potentially.
Maddie, when you went through that evaluation process, and again, I think for me, honestly, the big thing is I hear a lot about your GI tract symptoms, and it sounds like from an adolescent perspective, your major issues were gastrointestinal. My question for you is, when did that issue transition from a gastrointestinal issue mainly to a respiratory issue? When did you start noticing that change?
So that came when I was about 16 years old. I had become very, very ill in a short amount of time, and I was referred to an infectious disease doctor by my pulmonologist because they could not figure out through sputum samples or, labs what exactly was going on. It was evident it was some kind of lung infection. And so I saw an infectious disease doctor, started a relationship with her when I was 16. And then I was diagnosed. I was diagnosed with a lung infection called Mycobacterium abscessus. It took a while to get that diagnosis. At first, all my symptoms appeared to be tuberculosis. I had hemoptysis, I was coughing up blood, I had fevers all the time, really painful body aches. And so I was kind of quarantined until and I submitted a sputum sample that had to be, because I lived in Alaska, had to be sent out of state to be diagnosed exactly what the organism was. And then it came back that it was in the family of Mycobacterium, like tuberculosis is, but it was just a different strain or a different category than TB.
And what are you doing in your life at this stage as a 16-year-old outside of dealing with this diagnosis? Are you in school? Are you hanging out with your friends?
Yeah, right up until I became acutely ill, I was in high school. I was on my high school soccer team. I had friends. I was living pretty much the typical teenage life. And then this happened, and I used to jog, as an exercise and just for fun, for my mental health and everything. And suddenly I could not do any of that. I had to, I couldn't jog. I had to quit my soccer team. And then, as this was happening, my typical high school life really changed. And it's when my health really took the driver's seat of my life.
That's heavy. How was that for you emotionally? How did you manage that?
It was really hard. It was really hard. And I think for years, I didn't want to accept it. And at the same time, I was doing everything I needed to do for it. But I wasn't sharing it with my friends. And I wasn't talking about it openly like I do now. And I wasn't owning it or accepting it. at the time, as a teenager, anything different it's just hard to want that to be the case. And that's how it was initially for me. It was just, I don't want this. I'm not going to talk about it. I'm going to do what I need to do for it, but I don't want this to be happening. So it was hard mentally.
Yeah. Did you have anyone to lean on during that time?
I had my family, my mom and my dad and my stepdad, and yeah, my siblings at the time. Mostly family. I had a couple friends that I, eventually let in and would come and visit me in the hospital. I think the difficult thing with something like cystic fibrosis and the experiences that come with it is it's hard to feel like people can relate and can understand you. And I think I've always struggled with that. While I know I have a support system and people that care, it's always kind of hard to feel like people fully, understand, and that it's a lot of accepting the support that's available. And early on, it was more I wanted the kind of support that I thought I needed. And there was just a little bit of a disconnect there, but my family always tried.
Taking care of these teenagers, it's a different experience because you guys are going through puberty. You're having new life experiences simultaneously, and then you have this chronic illness that you didn't fully understand at the time. I guess, one of the things I always run into with teenagers is everything happens abruptly. They're like, oh, then there was the first time I was hospitalized and it kind of came out of nowhere. But then I go back and I ask and I'm like, do you think you started having symptoms from a respiratory standpoint well before that abrupt first hospitalization? Were you short of breath for a number of months, a number of years, and you just didn't tell anybody because of what you just said?
The answer would be yes. It's that whole you don't want to be sick. You don't want this to be happening. You just want to be normal. You just want to be typical. Even now, if I'm honest, sometimes I'll feel a little feeling. I'll have a dry cough all of a sudden. And I'm still like, ugh, do I need to say this to someone? Do I need to tell my transplant team?
Yes.
And I do that little internal battle. And then now, as an adult, I know the answer is yes. And I do that. But as a teen, it's not as quick to that decision. So, yeah, there are signs that I for sure was like, I just don't want to look at this.
I used to always say my patients in the ICU, the younger they were, the more they made me nervous because they were the patients that they'd be like, I'm good, I'm fine, I'm fine. And they wouldn't either recognize or they would suppress because, they're young and they're healthy for the most part. And so you wouldn't know things were really bad until, like, dare I say, it was almost too late. It would just be so progressive. And so when they finally turned the corner and everybody was worried, they're like, "Where did that come from?" But they just managed it so well until they didn't.
I feel like for me personally, I have a little bit of a different, like, yes, I had that rebellious, I don't want to take my pills. I don't want to take my pills in public. And I want to just ignore what's going on. But then pretty early on, like I said, as a teen, I had a lot of fear pretty early on that almost quickly snapped me out of that. I don't want to report my symptoms. I don't want this to be happening. The fear from, what my doctors were telling me, what was possibly coming or not coming, and the possibility of what's coming being death, really, that suppression of symptoms and feelings and everything like that was pretty much gone by the time I was 17, 18.
So just to clarify with you, you brought up the word death, and it's hard to even think or talk about. Was it that young that you were kind of facing the reality that death is, potentially something that could happen here? When did that? I mean, I just can't even imagine being that age and thinking about that.
I would say even sooner, the concept, even earlier in my life, the concept of death was present. I don't know how it is nowadays to be a kid diagnosed with CF and go into the clinic. I imagine it's different with the advancements there are today. But when I was a kid, even if it wasn't said directly to me, if it was said to my parent, I heard the age expectation all the time when they thought you would live until.
What they tell you? What age did they tell you when you first heard it?
The first time I remember hearing it, it was 19.
Oh my God.
I was not likely to live past 19.
That's correct.
And then as a teen, that was always in my head.
I have full goosebumps.
So yeah, that idea of death as a possibility, while not fully faced at a young age, it was there. And then as I became very ill, it was present and shifted, more into an action plan of preventing it and what to do to prolong my life to that point, and how to manage living with also dying.
Most kids who were going through what you went through, and most people who went through what you are going through, think about cystic fibrosis. The CFTR gene was discovered in like 1989 or 1987. You were diagnosed in 1993. The evolution and advancement of therapy for cystic fibrosis and the increase in life expectancy has massively shifted in a positive way throughout your evolution of your illness. And you are probably one of the few that has lived through the old school, the middle school, the new school way of managing and gone through so many different therapies as you're growing up. My question for you is, did you realize it? Because here you are telling us that when you first thought about death and you were thinking about mortality, you were told you weren't going to live past 19. Now knowing that the median age is like 55, 60 years old, whatever, and probably greater now, like did you have an opportunity to kind of sit and reflect, man, I'm living during a time when like these therapies have massively changed the trajectory of the pathogenesis of my illness? Is that something you thought about, can talk about, have written about?
I do think about that. Usually it's triggered by new treatment coming out, a new medication, a new research finding. Each one shocks my younger self. Each one brings me back to it's hard to even imagine how I started and how kids today born with this disease, they'll just have such a different experience, which is great. It's such a different upbringing, and with the new treatments, it really it's hard to even put into words the enormity of it.
Did you take any of those?
I qualified for one. I'm still taking it for Trikafta
Mm-hmm.
or Kaftrio in Canada and the UK.
Mm-hmm. That's the one with 3 molecules in it, right?
Yes.
How long have you been taking that?
Since November of 2000, it came out in 2019,
Mm-hmm.
right as soon as they distributed it. So I think November of 2019.
You've had a lung transplant and kidney transplant. When were those done?
They were done in 2022.
Again, when you look at the consequences of cystic fibrosis, and I'm just going to just summarize real quick, the mucus plugging, the persistent infection, and she had, what she was telling you is that she has an atypical mycobacterium called atypical Mycobacterium abscessus, which is an intracellular bacteria. Now, we separate out the mycobacteria. There's typical mycobacterium, which we call MTB or Mycobacterium tuberculosis, which is the one that a lot of people have heard about. Cavitary lung lesions, upper lobes of the lungs, persistent infection, on therapy for, over a year, things like that. Then there's the atypical mycobacterium. Now, these infections are chronic and people don't notice them because you have mild symptoms for a very, very long time. But they're typically in people that have distorted airways like bronchiectasis, which I'm sure Maddie had. Bronchiectasis is a dilation of the bronchiole. So the bronchiole, which is your pipe, and your pulmonary artery, which is carrying blood, they travel together in your lung. When your bronchiole becomes bigger than your pulmonary artery, we call it bronchiectasis. That's just what it means, right? But it's also become a clinical syndrome. Now, these patients may have atypical mycobacterium like Maddie had. The problem with these atypical infections is that they're present for so long that you start to get destruction of the lung because the immune system is there trying to get rid of it, and it can't because it's inside the cell. So the immune system tries to wall it off, and when it's walling it off, it can destroy your lung, and you get this persistent inflammation. And I think that's what happened to Maddie's lung. And so you had this lung destruction over the course of time that she had these mild symptoms and wasn't informing her physicians about these mild symptoms, but then the inflammation, the destruction just kind of continued over time, it sounds like to me, eventually to the point of no return, which was your mortality secondary to cystic fibrosis was going to be greater than your mortality if you had a lung transplant. So they elected to do a lung transplant.
Now, did your medical team come to you and say, this is what we need to do? Or were you kind of advocating that this is what you felt was necessary?
First of all, I like to say that, yes, cystic fibrosis caused my need for a lung transplant. But even more than that, like you bringing up Mycobacterium abscessus again, I believe antibiotic resistance is also what caused my need for a lung transplant because Mycobacterium abscessus was so resistant to everything that I tried and nothing ever touched it. And so I was on IV antibiotics every single day for 13 and a half years. And each year, that conversation of transplant is had. Even before it's like, okay, you need this now. You need this within a year. You need this within 3 years. It wasn't a sudden conversation. It wasn't a sudden realization or an unexpected one that I would need a transplant. But I do remember the day I was told that it is time. The phrasing was, to survive, you need a lung transplant now. And from that day, it took 6 years to find a transplant center that told me yes and
Oh,
accepted
wow.
me. My journey is kind of unique in that I could not get that transplant when I was told I need it now, or I needed it within 1 year. And so it was like a decade of this conversation happening over and over, even past the time that I needed it to be happening.
Now it's time for What's the Buzz, presented by BuzzRx. Every week, I answer a health-related question from one of our viewers. This week's question is a good one. Here it is. Doc, I heard some CF patients are stopping their older meds because of these new modulators, but how do you know what to keep taking and what to ditch? This is a very good question. You see, cystic fibrosis is a genetic disorder that leads to an absence or abnormal electrolyte channel that's called CFTR. In the lung, this leads to increased mucus production and an environment that's suitable for bacterial overgrowth. We now elect to treat cystic fibrosis by fixing or enhancing that CFTR. You're likely going to have to take that CFTR modulator, antibiotics, anti-inflammatories, bronchodilating medicines, and you're going to continue to use airway clearance therapies and enhance your nutrition. All of this is going to lead to better outcomes. As we advance in medicine, you are going to hear more and more about gene replacement therapy. That's the buzz this week. If you have a question, email us at healthexchangepodcast@gmail.com. And remember, go to buzzrx.com to look up your medication that you're taking to see how much you can save with their coupon.
So what happened over those 6 years that you were waiting, and how did that affect you?
When I was first referred for lung transplant, I did not need a kidney transplant. I had not been diagnosed with chronic kidney disease. And so the main focus was my lungs. But Mycobacterium abscessus is a complete contraindication for lung transplantation. Nearly all centers in the United States and in Canada. And so I kind of in batches was referred to different transplant centers, major transplant centers all over the country. I would either be referred and they would just quickly review my chart. I did a number of in-person, week-long, very invasive lung transplant evaluations. And every time I would get a phone call, I would receive a letter in the mail telling me I'm not an ideal candidate and they could not offer me the option of lung transplantation. Good luck. Let us know if you need anything else.
And it was all because of atypical mycobacterium.
Yes, correct.
As you're going through that, knowing that it's atypical mycobacterium and your physicians understand it's atypical mycobacterium, what did they do? Did they find a drug that eliminated it? Or did you just find a transplant center that said, hey, we're going to transplant you anyway?
I tried a lot of different routes. Early on, I had been referred to a specialist at the National Institutes of Health. And so for the primary management of my Mycobacterium abscessus, I was in a longitudinal study there where I would be managed by an expert who dealt with Mycobacterium abscessus all the time.
Did they eliminate the organism or did a transplant center just transplant you anyway?
So with being in a study over my lifetime at the NIH, I had access to different experimental drugs, different drug trials. I was in 2 experimental, compassionate release studies. One was a nitric oxide study, breathing in nitric oxide. It was thought to eliminate, I think, the biofilm of Mycobacterium abscessus. I tried all kinds of different medications, IV antibiotics, oral antibiotics, and nothing was ever able to get rid of it or kill it. And so I had to just find a transplant center that was willing to look at someone extremely high risk and basically just take a chance on me.
And are you finding these people, or is your care team helping you find these people?
When you're referred for lung transplant, regionally, there's kind of like easier transplant centers to refer people to. In Alaska, there is no transplant center. And so it's always referring out, and they have the places that they typically refer to, larger transplant centers. And so I did a batch from my pulmonologist of referrals to major transplant centers. And then my first in-person evaluation was my 4th rejection, and I took it really hard. It was very difficult. They put in we're not going to be able to offer you this option, how long they think you have left without it. It's just a lot of, I felt like I took a hit. And so I quit for about a year. I didn't want to talk about that. I didn't want to I didn't want to look at it. I didn't want to think about transplant. And I kind of resigned to the fact that it was probably not going to happen.
How old were you?
I was 25.
25.
I still managed my Mycobacterium abscessus. I was, still doing what I needed to do while becoming more and more ill, becoming kind of housebound. I was on oxygen all the time. I was diagnosed with kidney disease in 2017. And then just the second part of trying to find a transplant center did come from me. I remember just kind of having a day where it popped back in my head, and I just thought I wanted to live. I wanted to try to find this opportunity, and I was going to do everything I could. I told myself I'm going to make every single person say no to my face until I find that one that's going to say yes. And so I came up with a list. I did all this research about who has in the past transplanted someone with Mycobacterium abscessus, who has it as a contraindication, but still evaluates people on an individual basis, depending on smear versus culture of the infection, and put a list together and asked my pulmonologist, I want to be referred to these places. Can you please send my records out? And we just went down the list one by one.
And you say that happened kind of like in a day. Was there a conversation with a family member, or did you literally just wake up and you're like, new mindset?
It was a new mindset. I remember telling one of my family members, I want to do this. I'm going to do this. And they were kind of shocked. They were not expecting it. And I don't know what happened. I don't know what it was, but it just felt like something I could do again. It just felt like I needed to do this again.
This is going to be an odd question. Do you have a picture of your CT scan before you were transplanted?
I do. I have like a comparison.
I want the audience to understand what she's talking about when you have this organism that's leading to destruction of the lung. Okay, so you guys, when you're looking at this image, what you have is you've got 2 images right next to one another. You've got 2 lung CT scans. Now, the way that a CT scan is organized is we're basically slicing your body into cross section. It's just like shoot, 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 like really thin sections right on top of one another. Now, the lungs are supposed to be black. They're supposed to look like me, right? And everything with soft tissue that's white, right, it's either water, your heart, your blood vessels. Those are white things. But if there's white stuff in the lung, that's bad. So that's how CT scans are read. So when you look at her CT scan, what you're seeing is you're seeing these really dark black circles. These really dark black circles represent the airway, all right? And bronchioles look black, nice, well circumscribed circles. And when these bronchioles look bigger than the blood vessels that are next to them, we call that bronchiectasis. Now, when you look at her lung CT scan with significant cystic fibrosis in her lung, and this is obviously her lung that she was born with, you can see evidence of a significant amount of what we call bronchiectasis. You see those big black circles and those big black pipes. You can also see evidence of inflammation. So in areas where the lung is supposed to be black, but you see this whiteness on top of it or this grayness on top of it, that represents inflammation, infection, or water. In her case, it represented inflammation. So you've got this lung that is inflamed. You've got this lung that has significant bronchiectasis, and there's even evidence of some mucus on this CAT scan. So when you look at it, you know that the lung can't appropriately do its job. And I'm assuming at the time of this CAT scan that she had, her FEV1 wasn't great at all. I'm sure your FEV1 was less than a liter or something like that.
Yes.
So this is an individual that can't gas exchange very well, can't breathe very well. Now, when you look on her transplanted lung, which is the other picture, you can see that the blackness of the lung stands out. The lung is supposed to be black. It's a normal looking lung, right? And you can see that on the CAT scan when you look at both. Like there's the normal lung. I'm showing Savannah. This is the transplanted lung. And then you look and you compare it to her lung. And you can actually see the significant difference. Again, her lung looking more white in areas of inflammation, you can see, but more black in areas where there's significant bronchiectasis. That lung's not operating appropriately or efficiently. And that's the issue that we have on this CAT scan. It's probably what led to her having that transplant.
How do you feel when you look at that picture? Because I feel like I get emotional looking at it, and I can't even imagine what it means for you.
I think it's amazing. Strangely, a lot of how I feel when I look at these comparison photos, people might think that, I would hate my old lungs, my native lungs. I would, be mad at them, or I'd hate them, or, I didn't like them. They couldn't breathe and they didn't do what I needed them to do. But when I look at it, I feel like so much appreciation for my native lungs. And of course, my transplanted lungs, the difference is just, even to me, so it's shocking. But I also think of my original lungs. They did the best they could, and I just see them trying so hard when I look at these photos.
So you got to UCSF. They evaluated you for transplant. They said yes. What happened after that?
I was medevaced from Anchorage, where I lived.
Were you in the hospital at the time or were you home?
I was home, but I had to go into the hospital to get insurance approval to be medevaced. It had to be from facility to facility. So I went into the hospital simply to be transported. And then I was medevaced to Oakland on the other side of where I live now, and then driven over to UCSF. I was inpatient for 5 days. They've been following me virtually from like 2021 or 2020, actually, October of 2020. But because of COVID, I couldn't go. I chose not to go sooner than in April of 2022, just because there was no vaccine yet and everything like that. But so I got here, I was inpatient, and I finished the rest of my evaluation in the hospital
In 2022,
in 2022, in April of 2022.
when the pandemic was dying down. Okay.
UCSF and I felt like it was the right time. I needed to do it. And so I came here without any, commitment from them. The response was still, we do not know that this is going to be an option for you. We do not know yet if we can offer you the option of lung transplant. And so we talked about, what would that mean? I would come here and be evaluated. What if I couldn't come to UCSF? Like, what if you guys told me it was not an option? And they said you would just turn around and we'd medevac you right back, and that would be that. And so at the end of my 1 week evaluation in the hospital, they came in and told me, we're going to discharge you from the hospital, but we have not made our decision yet. So you're going to have to stay in San Francisco until we make our final decision. We have to discuss as a team. It's going to take more than just one discussion as a team to make this decision for you. So I was discharged. I lived in a hotel, and then it ended up being a month later.
A month.
A month. I stayed in a hotel that whole time, and then on May 18th, they called me and they said, "Okay, are you ready to go on the list?" And I said, "Yes."
Oh my God.
Savannah, during the story, you were shaking your head. I want to know why.
Well, it's just, I mean, this journey is you're just blowing me away. And I'm trying to put myself in the position of these doctors and these providers who are having to make this massive decision on your behalf and make sure that it's going to, work out in the way that they want it to. And I'm trying to put myself in both of your shoes. I don't know how you did this. I mean, just the mental strength that it takes and the way that you're presenting yourself right now is incredible. But as you're saying this, I'm thinking, here you are away from home. I don't know if you brought family or not. When you said that they discharged you, I was blown away because you've been there for a week. You don't have an answer. And then they're like, you need to leave, but don't leave the city. And they just want you to sit on that. Now, from their perspective, they're less probably worried about how you feel in that moment and making sure they're making the right decision. But nowhere did I think that you were going to follow up with staying in a hotel for an entire month. Did they call you and say, this is where our head's at? This is why it's taking this long. These are the conversations we're having? Or was it like ghost town?
There wasn't a lot of communication after that 1 week. It was mostly I had to wait. I mean, they had all the information they needed. They were going to be discussing my case is all I was told, and I was told it was going to be more than one discussion because everybody on the team, including the infectious disease doctor and his team, had to all say, "Yes, we can do this." And so it was waiting. I still tried to live a little bit of my life while I was waiting that month, but it was kind of a numb month as well.
It's hard because, like, being in the rooms like that and listening and participating in these conversations, when somebody's going through a transplant, and most patients don't think about it this way. And I know that Maddie probably has now, but you're treating one disease for another one, right? That's what you're doing. And you have to ask yourself, is this person going to live through what I'm about to put her through? Or am I accelerating her death because I'm putting her through this? It is a huge decision because you've got to talk to the surgeon, the infectious disease doctor, the primary care doctor, the transplant pulmonologist. In her case, the reason it probably took so long is they're probably evaluating her kidney too for transplant. Now you've got to talk to the nephrologist and the transplant nephrologist. You've got to talk to all these teams and the intensive care unit team. You've got to talk to all these teams because as she's getting transplanted, this is a lung. This is an end organ. Nobody else could do this job. Kidney, you could do dialysis, no big deal. Lung, bigger deal. We're talking
Yeah.
if she needs to be transplanted, she's going to be on ECMO for a little bit. There's all these things that are involved to have to support her. Now, as a patient, you're kind of like, yo, am I going to get this or not?
Well, Maddie, do you feel like your voice was being heard through this process?
I think some of the providers really heard and recognized what I'd gone through to get there. It is hard in the transplant process to feel like you're heard and almost like a person, really. It is true. They have to weigh if the benefits outweigh the risks and everything like that. And from the doctor's perspective, yes, it does make sense. And as a patient, I fully understand that. And I get more than they might think. I get the reasoning and everything. But as the patient, it can be kind of a almost dehumanizing process because it's not like you're applying to a college and they're potentially telling you, we're not going to accept you in. It is for saving your life. It is a life-saving procedure. And so it's hard to feel like you're fully recognized as a person with a soul who is worth a chance, which for me, it was over and over and over trying to convince someone that that is what I am. And so I felt heard, but I had so many past experiences with me at that moment. And I also just kind of felt like, well, it's out of my hands. I can only do so much.
You can only do so much.
Transplant is both a life-saving and life-ending procedure. And we often don't say that part. We always say life-saving. It's life-saving because that's how we look at it. But unfortunately, from an objective perspective, as a physician receiving the transplant patients, as the surgeons who are operating on these transplant patients, they know. And so it is objective. It is dehumanizing. It really is. Because not only are we thinking about giving this person an organ or 2 organs, but we're also saying no to the person that's second on the list. We're saying no to the person that's third, fourth, fifth, sixth. Unfortunately, because there's not enough organs that are able to be passed out to everybody who needs them. It is dehumanizing. It's purely objective. It's a rank system. It's all of that. But what she did do, she advocated for herself and she told herself, I'm not going to be just another number. You guys are going to know that my name is Maddie Deaton. And I think that that is powerful. And I think that that's awesome. And I think it contributed to where she is standing right here, right now. And that's a wonderful trait. And that's a wonderful thing. And I think that's beautiful.
Thank you.
So it's May. You got listed in May of 22 or 21?
2022.
Okay.
Yes. And I actually found out when I was told we're putting you on the list. I did not know at that point that I was going to be listed for both lungs and a kidney.
Yeah.
They told me at the time, or I asked, so when am I going to be getting my kidney and being listed for the lung? Is it going to be 6 months later, 1 year later? And they were like, oh no, we're just going to list you for both. So
Were you on dialysis at that point or no?
I was not on dialysis.
Okay.
I had had a fistula created. I was preparing for dialysis, but with CF and the lung function I had or did not have, they were very scared to put me on dialysis because they thought it would, make my lung condition worse. So it was prolonged as long as possible. So I did not have to start it.
So it's May 22. You're on the list.
May 22, May 18th, I go on the list. I get a paper in the mail saying you're officially on the lung transplant list. And I'm on the list. And then at the end of July, I get COVID and parainfluenza. I do a viral swab and both of those come up. I am inactivated on the list because you cannot be on the transplant list and have a virus. And so I had to wait for both of those to clear my system, and I had to test negative 3 times in a row to be activated again on the list.
And I assume you were treated with Paxlovid and oseltamivir or baloxavir or what? Tamiflu.
No. So because of my kidneys, I could not take Paxlovid. I did the monoclonal antibodies
Oh, you did monoclonal.
infusions.
Okay.
Yes. So I did that and it helped. And then I didn't have any severe symptoms. I didn't have to go into the hospital or anything like that. And then 1 week before I got the call that there was an organ offer available is when I was reactivated. So I was back on the list for 1 week, and then I get the call
What month?
on August 19th. The evening of August 19th, I get the phone call. It's like 11 p.m. And then everything got very real. It got very real at that point.
Maddie, you've given me goosebumps. I kid you not, at least 10 times during this entire interview. What happened from there?
The call itself was terrifying, contrary to what I think a lot of people think about receiving the phone call for this kind of, life-saving procedure. I was so not prepared and not ready. I immediately texted my mom. I'm trying to absorb what the woman on the phone is telling me I need to do, but I'm like seriously freaking out inside my body. And I tell people now, I wanted to say no. I wanted to say, I'm not ready. Can you call me back in a couple weeks? It's just the most terrifying moment, I think. Second to going down to the OR. But I listened to everything she said. It was really late at night. So I had to wait for a bed to become available. The lady on the phone told me to go back to sleep, keep my phone on loud, try to get some sleep, which is impossible.
Yeah.
But and then they would call me when a bed was available, and then I would go to the hospital. So it was probably 4 a.m. on the 20th is when I had a go bag ready. I had things packed in a suitcase that I was going to bring to the hospital with me.
Are you
I
by
was
yourself or are
alone.
your parents there? You're by
I
yourself.
was I was alone.
Yeah. Oh my God.
So I had a go bag, I had a pillow, I had my, portable oxygen. I called an Uber and I put everything in an Uber and Ubered to UCSF at about 4:30 in the morning.
Maddie, you're Superwoman.
Yeah, you're Superwoman.
Literally.
Maddie, though, hold on. I gotta ask you this. Where were your parents?
Well, they were at home in Alaska. I am a very independent person. I've always been very, very independent. As soon as I got the call and let my parents know, they were on a flight. They
Okay.
booked a
Yeah.
flight and they were at UCSF before I went into
Okay.
the OR. So I'm very independent though. So it's not abnormal that I'm going through crazy things by myself.
Well, given your life story, of course you are. When you were talking about that fear when you got the phone call, where did the fear stem from? Was it fear that it wasn't going to go well?
I I was terrified of the change.
Yeah.
I was terrified, what I was living in was familiar. I knew how to do that. I knew how to live in end stage respiratory disease. I knew what I was doing. I knew how that was going to feel. I did not know how having a lung transplant and a kidney transplant was going to feel. I didn't know if I was going to make it. I didn't know if I was going to make it a year. I didn't know anything about what that was going to be like. And that was terrifying to me.
So then you're going down to the operating room. You said that was the most fearful moment.
Yes. I had to do a bunch of testing, so it took all day, on the 20th, and then at 7:30 PM on the 20th, they came to get me, and my parents walked me, as far as they'll let your parents walk with you or someone walk with you to the OR, and I was you're fully awake. You go into the OR, and they just start doing things around you, and those moments of thinking about what is about to happen to your body. My lungs, were going to be removed. That was a very huge thought. And I was going to be in there for hours and I was going to, you know, be vulnerable and have like the most intense things done that a person can have. And um, I went in there and laid on the cold bed, the slim OR bed, and I was just sobbing, crying, crying, crying. Um, and one of the nurse practitioners who wasn't doing anything, she was just kind of observing, came over and she could see tears, when you're laying down, they're going into your ears. And she just said, can I talk to you until you fall asleep? And so she held my hand and she asked me questions and I don't know, I said words to her and she talked to me and then I was asleep.
That's the nurse.
When you were lying there, and I know this is kind of like a very honest question, but were you worried about dying? Was that going through your
Yes.
head?
Yes.
Did you say anything to your parents before you went in?
Just I love you. And they said, I'll see you when you wake up. I'll see you when you're out. And yeah, I love you.
What was the post-operative course like? I'm assuming the operation went well.
Yes, the transplants went well. The only
Hiccup.
hiccup or thing that they noticed that was different was when they removed my right lung, I had undigested food in the upper lobe of my right lung. So I had been aspirating for a period of time before my transplants and was unaware because I had no feeling or I had lost, blood flow to that area. And I just didn't notice I was aspirating food.
They didn't find a fistula. They must have they had to look for one. They probably didn't see it. Okay.
My surgeon could see it with his eyes. When he removed it, he could see it. And then I couldn't eat by mouth for a while after my transplants.
Did they do a swallow study and see it?
Yeah, so it was kind of an interesting development. First of all, coming out of my transplants was like a whole different world. It was like a completely different experience than I've ever had. But I did have a swallow study. I had a couple in the hospital and I passed them. I had a little bit of, my esophagus pushing food back
Yeah,
up or pushing the
regurgitation.
liquid back up,
Mm-hmm.
but none of it went down into my lungs. But the lung transplant surgeon that was on service while I was there was not my lung transplant surgeon, but she was not comfortable letting me eat by mouth. And she told me at the time that I would not be able to eat by mouth for up to a year.
Oh, wow.
So postoperatively,
Yes.
they discovered that your right upper lung had some food. Now they don't want you to eat anything. How was your postoperative course overall? You didn't have any acute rejection, it sounds like. Sounds like everything was okay.
I did not have acute rejection, and I only had one positive culture of Mycobacterium abscessus within that first week after my transplants, which they told me they would expect to see any, residual bacteria in my upper airways might show up. And I stayed on my antibiotic regimen for Mycobacterium abscessus for 6 months after my transplants, just to make sure everything was killed if it was there.
You had no need for anti-acute rejection medicines.
Hmm.
So they put you on prednisone, mycophenolate mofetil, and tacrolimus right away.
Yes, I got a big giant dose of steroids in surgery, like 1,500 milligrams. And then, yeah, immediately started on prednisone and my immune suppression medications.
Now, for the audience, when you get an organ transplant, because of the organs coming from other individuals, your body is going to recognize these organs as non-self. When these organs get transplanted, they have white blood cells within them. And these white blood cells within these organs are going to travel to local regional lymph nodes. And the white blood cells of the original patient, they're going to be like, who the hell is that? And in the process of your body, of that patient's body saying, who the hell is that? They're going to create a little bit of defense against those things, which means because of those white blood cells having some of the same receptors on their membrane that the organs that the patient has received have, that means that you're going to develop some type of inflammation within those organs. And we call that like chronic lung allograft syndrome, right? CLAD, right? Which is just chronic rejection. And so from a lung perspective, because the lung is constantly exposed to the environment, when you look in literature, areas in the country where air pollution is the worst, rejection is also the worst, because it makes sense, because when you breathe in all that crap, you're just stimulating inflammation. But Maddie probably had to go through a period where she was having a bronchoscopy. We would look inside the lung and we would biopsy the airway to look under a microscope to see how much inflammation was taking place, right, Maddie?
You get a schedule, a 5-year schedule, and you have testing, periodically within those 5 years. Within the first year, it's very frequent. The first week of my transplants, I had a bronchoscopy every single day at the bedside. And then it kind of spaces out from there. And then after 2 years, it's even less. So they're very rigorous with testing and checking for rejection.
And you've never had a period where they had to give you a dose of anti-thymocyte globulin or some other rejection medicine. You've been cool.
Yes, I've been cool.
Yay!
That's great. That's fantastic.
Yes.
Have you had, and because you're immunosuppressed and your immune system, and most of the time with chronic rejection, you're trying to fight the T cells and the B cells, the cells that present antigen, the cells that make antibodies. But that puts you at risk of infection. It also puts you at risk of skin cancers and things of that sort. Have you had any infections at all in the last couple of years?
I have not had any lung infections. I was diagnosed with I had some skin cancer removed that I developed about a year and a half in. I had Mohs surgery and got rid of it all, but no lung infections, no chronic infections.
So you have done very well. And you know that.
Yes.
You know you've done very, very well.
Yes.
It's wonderful.
Your story is absolutely fantastic. And it is the best outcome that we can hope for in this situation. I mean, honestly, like you've done so well.
What does life look like now beyond transplant?
That's a good question. It's very open. I have been able to get back to the things that I lost pre-transplant, like walking outside my house, discovering new hobbies, rediscovering old hobbies, connecting with my friends. One of the biggest things that is different now is I can be there for my friends and family for like important moments in their lives, where before I would miss weddings, I would miss, baby showers, very important things I just could not be a part of. I have found, in my post-transplant journey, I have found like a voice spreading awareness and talking about CF and talking about transplant and what it really looks like, what it really, you know, entails is something that has become very important to me. I went from thinking I had no future to now I have this, endless opportunity kind of future, which while it's what I wanted and I mean, I'm so grateful like to my donor and my donor's family for that chance. It's also very daunting in a lot of ways as someone who has primarily lived a life with chronic illness and then an end stage respiratory disease. It's hard to know exactly or see what is next and figuring out that identity as an adult who does not have these issues at the forefront is a challenge I feel like I work through every day, but in a good way.
What do you do for a living now?
I write for a publication. It's a publication called CF Roundtable. It is adults with cystic fibrosis share, write articles, share perspectives and stories and things like that.
Besides the theme of resilience and advocacy and self-advocacy, the other thing I hear is access. You had access to the health system. And then the other thing I also hear is you must have had to be able to go somewhere for a month, to be able to live somewhere for a month in hotels. You had to have the means or something, right? And to support that. Did you had all of that? Your family had all of that and they were able to support you through that?
My parents supported me. They came to, visit me frequently. They came to be here with me after my transplants. My older brother, huge shout out to my older brother. He put his whole life on pause. He lives in Washington State. He has a family. He has a wife and 2 kids. And he left his home with his family's support, all of them. He came here for almost 3 months and was my 24/7 caregiver and took care of me and
What a
helped me
brother.
recover and was here every step of the way and never left my side and was my cheerleader and was able to like be the rock of my recovery and get me through everything.
What a brother.
What a brother.
Yeah.
Maddie, thank you so much for sharing this story. I think you touched our hearts in a way that we were not expecting, and you are going to touch so many others' hearts in general and through this podcast.
Normally at the end of an episode, we do something called a positive pulse. I don't think we need a positive pulse because you are the positive pulse.
I agree.
Just hearing your story and what you had to overcome and to really hear you understand every single aspect of it and to reflect on it, and now to be working in a career where you are supporting others through your experience is an amazing positive pulse. Do you have 3 tips for advocating for yourself as a patient?
3 tips for advocating for yourself. 1, don't care about the ramifications of advocating for yourself. If it's gonna make you like, don't care if it's gonna make you look any way, make someone view you in any way. You are the only thing that matters when you're advocating for yourself. Ask for help if you can, if you have a family member, if you have a close friend, if they just stand next to you while you're fighting for your needs. You're saying what you need. You're saying, no, I don't want to do this. Yes, I want to find a different solution. So having someone just present with you is powerful, I have felt. And don't give up. If someone tells you no, go ask someone else. If a transplant center tells you no, that does not mean it's never going to happen. That does not mean you stop right there. Go to the next door. Make them all tell you no to your face, because someone is going to say yes.
You guys all heard it from Maddie. Advocate for yourself. Don't take no for an answer, and have significant support. That's what it takes. And she did that. She's demonstrated that. We really appreciate you, Maddie, for being on the Health Exchange today. Thank you so much for being here. And you're going to teach so many of our audience members. And we'll see you guys next time. Thanks a lot.
Thank you.